How do either of you, so when you, it's been my feeling that when patients progress to this state, in other words, they are in this castration-resistant prostate cancer M1 disease. So by definition, they have prostate cancer, they've been on hormonal therapy, they have a rise in their PSA, we do radiographic imaging, and they either have bone metastases or soft tissue disease. It's always been my feeling, having watched these patients, having discussed this with my partners, is that these patients oftentimes are minimally symptomatic, asymptomatic, they're functional, they're playing golf, they're fishing, they're still doing their normal deal. So to bring them in has been, I believe, a real problem because we have not emphasized how quickly these patients can progress to become symptomatic and have a median survival of somewhere around 20 months. So when you bring these patients in, when you try to educate them, especially when you talk to them about what is clearly a new class of drug, something that I believe in this age of personalized health, personalized medicine, where everything needs to be individualized, you explain to them that this is a therapeutic vaccine. What seems to work in your experience so far on how to get these patients to accept the fact that this is a recommended treatment, there is a survival advantage? How do you tend to explain that to the patients, how the therapy actually works?
Well, first of all, I would tell you that most patients have probably been in our office for about 10 to 15 years. And one, they do not want to go to the oncologist at this point in time. They kind of feel like you might be abandoning them. They are all very cognizant of what is going on with their PSA. They're very focused on that. And so they understand that there's been some progression in their disease, and so they're very open to the discussion. And when you explain the differences in immunotherapy versus chemotherapy and the potential side effect profile, I think they're all very excited about the opportunity to participate in immunotherapy. They realize that, you know, again, it's there's a definite survival advantage, number one. I think they also realize that the toxicity of chemotherapy at this point in time is something that they probably don't want to do. And when you explain to them how easy it is to go through the leukapheresis process, how to get the infusion in the office, how you're going to be monitoring them and keeping in close contact with them, there's usually a very good acceptance of the process going on.
Bryan, has that been your experience? Because I know you've treated 25 patients.
About 25 now. So I think in, in Eugene, when you can tell a patient that, you know, we're going to train your own immune system to attack your prostate cancer. This is not a drug. This is not a poison or anything like that. I think that patients understand. I try and emphasize to them that this is kind of a platform of immune therapy, and then other therapies can follow. It doesn't preclude doing anything down the road. And, you know, relative, you know, risk-benefit analysis, it's a lot of what we do when we talk to patients about anything. There's not a lot of risk associated. There's some really fevers, chills, minor kind of side effects, and there is this survival advantage. And I guess the only other thing I would add is I kind of emphasize to patients that if we're going to do this, there is an immunosuppressive effect of advanced prostate cancer. The bigger the tumor burden, the tumor itself has an immunosuppressive effect. So if we're going to do this immunotherapy, I try and emphasize to patients it's probably better to do it earlier. Your immune system more likely to have a more robust response to the immune therapy if we're going to do it early rather than late.
I think that the way that I kind of view this is that, again, I think Provenge or Sapulacel-T really, very much like ADT is the cornerstone for patients when they first fail. Once they start to fail, once they start to become castration resistant, to me, by enhancing their immune system, by getting Sapulacel-T on board, which again, as many of, you know, as we know, it's approved for the asymptomatic or minimally symptomatic patient with castration-resistant disease, that it's 3 infusions essentially given over 4 weeks. And once you get that in, the treatment's done, they don't feel bad, you don't, and it doesn't preclude the use of any type of other therapeutics. Now, let's digress a little bit. We had talked about the use of denosumab, which is a rank ligand inhibitor, in the use of patients with high risk developing basically decreased bone mineral density, or have bone mineral density loss. So once patients become metastatic, what else do you, and again, because about 90% of prostate cancer patients develop bone metastases, what are the other therapies that are out there specifically relating to bone metastases?
Well, what I would tell you is it the job of the urologist to not only manage their prostate cancer, but their bone health and all the metabolic consequences associated with some of the therapies that we deliver. In San Antonio, we've also incorporated ExigeEva in the management of our advanced prostate cancer patients once they have bony mets. It's delivered a little differently than Prolia. It's delivered monthly, 120 milligrams sub-Q. It's in order to have maximal prevention of bone reabsorption. It's in the clinical trials was shown to prevent SREs in a highly significant manner compared to this gold standard, which was Zometa at that time. We find it very user-friendly in San Antonio in that it is sub-Q. It's not an IV infusion. I don't have to worry about what their baseline renal function is. I don't have to monitor the dosage of that regarding to the renal function. We do have to be a little cognizant of their vitamin D and calcium status, and then of course we make sure, because there's a 1.2 to 1.8% incidence of osteonecrosis of the jaw, we make sure they've seen a dentist ahead of time and they have all dental care taken care of beforehand. But it's fit in nicely with our prostate cancer care in the advanced patient.
So Bryan, you said you did not give Zometa,
Right.
and I think that's been the experience of many urologists, is like you indicated, Zometa or zoledronic acid is an intravenous bisphosphonate. It requires an IV infusion. It requires monitoring of renal function. It's infused over an hour. So a lot of urologists were not giving Zometa, but understanding that we had patients out there with metastatic disease. So now that a different drug is available, what's been your uptake by your group with the use of ExigeEva?
I think pretty much we all understand that when a patient has metastatic disease, those patients tend to have problems. And the data with ExigeEva is good. The administration is simple. When they come in for their monthly visit, if they don't have other issues going on, they come in and see our nurse, get an injection, and leave. It doesn't even involve the physician that visit. And I think you got to monitor their calcium levels. Occasionally I've had to stop ExigeEva if a patient develops a dental problem and then they're going to have an extraction. That's about really all there is to managing, just paying attention to those issues that Dan already mentioned.
See, I think by having these two particular therapeutics, by having ExigeEva, which again is a sub-Q injection, patients like it, they can come in, they can get out, and obviously having Sapula-Cel-T, which again is so you've got ExigeEva that's really treating their bones but not necessarily treating the prostate cancer. Then you layer in the Sapula-Cel-T or Provenge, which actually is addressing their cancer cells. Again, to me, this serves as the cornerstone in my mind, and really what NCCN recommends is that in the patient that is minimally symptomatic or asymptomatic that has metastatic disease, this should be one of the lines of therapy, and NCCN also talks about possibly looking at a clinical trial, which of course there's many of us that are involved in research. But again, I think the beauty about Sapula-Cel-T is that it's immunotherapy. We know that there are a couple other drugs in phase 3 trials, specifically that's an immunomodulator, Prostavac. The other one is ipilimumab, which is actually approved for metastatic melanoma, but is also being looked at in the metastatic prostate cancer patient.